instance. And I'm showing this again because I'm showing a different aspect of this picture. This is probably a medical student examining a patient. I say that because his white coat is very short, and at least in North America, short white coats imply you're a student, and the longer your coat gets, the more experienced you become. So if you see someone with a short white coat, you might want to ask them if they're a student and how much experience they have. In any case, he is examining the patient from the right-hand side, as you'll notice. The next image is a clip of a teaching video I have from medical school demonstrating how to examine the abdomen. But I want you to also notice that this examiner is also standing on the right-hand side of the patient. And in fact, North American Medical Convention states that you must examine patients from the right-hand side. Much of this is convention, but there are reasons anatomically to do so. There's a number of vasculature reasons in the neck we examine, the liver. It gets to the point that for medical school exams, you can lose points or even potentially fail an exam if you approach from the left. It becomes ingrained in us as physicians. I'd be interested to know if it's like this in other countries. I don't know necessarily. But I can tell you the next slide is going to show you the clinical exam room I had for 3 years as a resident doctor. So I'll ask you, do you think I can examine from the right-hand side as I've been taught with this design of a room? Right, I can't. And so the built environment does more than simply provide us respite. It impacts our work patterns and our efficiency quite a bit. And so now I'll take you into the trenches. You might have heard this expression, but in medicine we like to say going into your residency or your training period is sort of akin to going to battle. You put on your scrubs or your uniform, go into the trenches, you put your head down, and you get through it. There's been some association shown between rotating night shift nursing work and a risk of coronary heart disease, in fact. We know that shift work is not necessarily healthy over the long term. I'm more interested in this image and what's going on here that we can't necessarily illustrate, the sound and the lighting. But you can see there isn't much daylight. You can probably imagine the noise and the chaos. This is a slide I made to show you what I consider to be the no sun zone of the staff corps. This is a floor plan of a critical care unit, but you can see that the perimeter is given to patients. They get the daylight. Staff gets the inner core. When I was in California last year for a board review class, I overheard 2 doctors talking. One said, "I have 2 clinic rooms. One has a window and one doesn't, and I find myself preferring to be in the one with a window. I don't like spending time in the other one." And then the other doctor said, "My office actually has a window with a view of the parking lot." She was so excited. The other doctor looked at her and said, "I can't believe you. You're so lucky. I don't have an office with a window at all." And all I could do sitting there listening was think, this shouldn't have anything to do with luck. They should always have some sort of window if they're sitting there charting at night, late into the night, many hours. And, there should be minimum building code standards for staff, which there are not at the moment. Now you might look at this floor plan and say, well, it's tricky to get light into all these spaces, and it definitely is. But there are innovative ways to do so. I'll show you some pictures. In Finland, the sanatorium, I keep coming back to, but this is a single loaded corridor, rooms on one side, windows on the other, painted a wonderful yellow color, beautiful space. I still remember being there. Wonderfully sunshiny and uplifty, bringing light in. This slide shows on the left is also the sanatorium. They've put light wells in, so bringing light deep into a core of a space is one option. And on the right-hand side is a Canadian example in Toronto, the Credit Valley Hospital, using these wonderful tree-like structures in an atrium to bring a form of nature in. And let's bring in an Australian example. This is an ICU in Melbourne, Australia. This actually brings in clear story windows into the staff core, so you have light into the core where the staff are, and patients actually get only the borrowed light. They don't have windows themselves. I recognize this is something that can't be done by building code in all places, but it's one solution that I've seen over there that I think works quite well, that I wanted to show. So this is a topic or a symposium on mental health. I'm talking about mental health and design. I have to talk about burnout and the environment. It's splashed across the media all the time now. There was just an article this morning someone sent to me, in fact, but it's been in all the big newspapers in the last few years. Burnout and the environment, the epidemic of disillusioned doctors. Another headline, Canada's doctors, the best, the brightest, and the burnt out. And I quote, evidence is starting to accumulate that burned out doctors make more errors, are more prone to substance abuse and depression. I thought I would read an excerpt from my diary as an intern, my first week in the intensive care unit. I contemplated whether to read it or not. It takes about a minute and a half. It's quite personal, but I think it makes the point that physicians too are human, and we struggle with a lot of the things that we have to do as doctors. So I'll read it, and maybe we can talk about it at the end, but I think it serves to illustrate the fact that, the idea of burnout is real, and the amount of chaos and trauma that we see is real. And it's something that I think, at least myself as an architect, I feel very passionate about, that we need to begin addressing through the environment and also through how we train physicians and the amount of hours they work and the resources we give them to try to deal with some of these stressors. So this is going to be transcribed for everybody because I've sent a document, but I'll read it out loud at my own pace. I have it in front of me. So this is the first week of ICU. All you have to do is try and survive, a senior resident said to me. But I close my eyes and I still see their faces. The young man in his 40s in the corner room who had back pain, and he took too many Tylenols, now lying in a bed in a coma, yellow and swollen, and waiting for a new liver. Don't worry, my attending said as we were rounding. Weekends are pretty good for livers. How morbid. I left the rotation before I even knew if he got an organ, but later I found out that he died before one was available. A 32-year-old woman with end-stage AIDS and encephalitis. She lies there with eyes that follow you, just like a Cabbage Patch doll, said my resident. She's unable to speak. When we ask her to squeeze our hands, she remains limp. But when we ask her to blink, her eyelids open and close. Can she understand us? How frightening to think of such things, the locked-in state. After I left the ICU, I found out that she had died too. This week I performed my first chest compressions on a human being, a 57-year-old woman with no medical history who fell down suddenly in the park. I declared her time of death. The family cried the whole day, and many came in and out of the room. The death was way too sudden. The space they had for mourning was only that room, and just outside, in the middle of the ICU. It was not peaceful, with the unit still bustling and noisy behind them. On rounds our attending mentioned patients were not able to sleep in this environment, and I commented that sleep and food deprivation are forms of torture. He looked at me and agreed, but was very clear that we are not doing it intentionally. I am not sure I agree sometimes. The environment does not allow for patients to sleep. We order labs and x-rays and wake patients up every few hours. We put tubes in their throats, noses, necks, bellies, veins, and arteries. Are we doing any good? As I sit in the nursing station to try to write my notes, I cannot think. Machines are beeping. The nurse call button noise is unbelievably irritating. Phones are ringing. People are talking. Doctor, can you reorder the restraints on bed 14? Doctor, can you change the diet order for bed 22? And when I look up from the nursing station enclosed on all sides with a mid-height counter to shield us from the patient and family side, I see them all, lying in beds with tubes and ventilators. Some are quote-unquote actively dying, as we say. Some are getting ready to be transferred to the floor. They have survived the ICU, but have we? So that was just a little excerpt from a very emotional week in the ICU. And I have to say that when I was in those states in the ICU and thinking about all that emotion, this is where I would have liked to have gone, to a window to see these kinds of views that we had in New York City, readily available to us. And I always found that seeing the sky after a shift was very powerful because it made me realize what a big world we had out there and how small we really are and the meaning of life. But I can tell you I never was able to go to see a view like that, and this is where I would go. So this is a clean supply room. This is where you'd often go and see someone wiping away a tear in the corner beside some stacked bins of gauze. There's nowhere else to go to take a moment. At nighttime, I think you can imagine the hospital changes quite a bit. There's less beeping, less chaos. I actually kind of liked it, except for the torture of trying to stay awake when your body begs for rest. But I have to tell you that sitting down and closing your eyes, even for 10 minutes, can refresh you for hours. Some of you in the audience might be aware that work hours have changed quite a lot in the United States in the last few years. And this takes time to explain, and I won't take the time right now, but only to say that there's a big debate right now going on. My sketch depicts the old-fashioned model of a 36-hour shift, and you see the doctor there, versus the newer model with shorter blocks of 16 hours, but that requires you hand off to somebody. So, new doctor comes in, you need to get that information, and it's very easy to say to someone, that sounds like a better model. But there are caveats, and we don't necessarily know. The handoff is a very dangerous period. It's very difficult to hand off information within seconds that, having known a patient for hours, how do you hand off information in a minute or two? And where do you do that, in fact? We have no handoff spaces that are quiet, that are conditioned for this type of information exchange. So, in fact, this summer in the United States, shifts are now changing from 16 hours going back up to 24 based on some new research. So it's not decided what kind of shift is actually best for clinicians and safest for patients. The idea of the on-call room is something I think you might be familiar with. The call room with the double bunk beds with hospital sheets, no computer or nightlight, kind of makes it a difficult place to sleep if you even have time to go. And if anyone in the audience can tell me how to get to the top bunk without a ladder, I could never figure it out. So I'm all open to ideas. Also on my obstetrics rotation, you could never go here because you'd miss the delivery after you'd have to run 3 hallways down. So often placing the call room in the right location is important when you think about design. Call rooms are not used much anymore because we don't work 36 hours, so you don't necessarily need to sleep. So this hospital administrator came in one day and said, we're taking your room away. You shouldn't need to sleep at all. I don't agree. I think we still will always need to rest. This was an interesting article in the Huffington Post. It was a couple of years ago now, but I think it's worth mentioning. It might be hard to read, but you don't need to read it. These bubbles show on the left money raised for different diseases. The pink is breast cancer, the orange is prostate cancer. But on the right, it shows you what we actually die from. Purple is heart disease, and right under that is COPD, lung disease. So a bit of a disconnect, perhaps. So one day in the hospital, I started sketching. Well, this reminded me a little bit about where we spend our money on design and hospital space. And I came up with my own, money raised versus what really happens. And to me, on the left in blue, I thought we really put quite a lot into patient rooms and patient spaces. And to me, staff spaces in yellow are quite near the bottom. But in my dream world, on the right, I saw interdisciplinary staff spaces to be number 1 in terms of priority, and then procedural rooms and patient spaces just under that, because we're moving so much into an interdisciplinary model in healthcare. And research is proving that. This is a Johns Hopkins study. Very busy slide. Don't worry about it. Look at the pie chart. I can tell you that if you think the orange is us with patients, you're wrong. We spend 7 minutes a day with a patient, 12% of our time. So that little red wedge, or the red part of the pie chart, that's our patient time. The huge orange part of the pie is us talking to providers and charting. It's a very different shift in medicine of what doctors are doing. So space and architecture has to reflect that shift. I guess what that orange represents is collaboration. So some buildings have addressed that in science and research. The Salk Institute on the left in California, and the Terence Donnelly Center in Toronto in Canada on the right. They've designed for collaboration. Look at what they've done. They've incorporated blackboards and whiteboards. 80% of discoveries don't happen at the lab bench. They happen when you bring people together to communicate and think together. If that's the case, what about the idea of the doctor's lounge? There was a neat publication in Canada a few years ago saying, well, the doctor's lounge is actually almost non-existent, which I would agree with. So if that's the case, where is this new hub of activity? So where are these relationships thriving and developing? So I can tell you what I think, just a theory. Two places. One is the corridor. Very underutilized space. We have a minimum standard of 8 feet for a corridor. Rare to see it bigger. People don't want to spend money on big corridors. But a lot happens in the corridor. We round in the corridor. We gown and glove. We chart. We have life and death family discussions. Patients do their physical therapy. A lot happens. So can it be more? Can we design for it to be more? Can there be alcoves, gardens? Can it be more interesting with artwork? And this one's my favorite. People would ask me, where did your best conversations take place with the care team? It wasn't necessarily through our pager or on the phone. It was while we were on the fire stairs. Very difficult to take an elevator and talk about patient cases because of privacy laws, especially in the United States. So on rounds, we would go up and down using the egress stairways and often bump into consultants. Say, oh, we were just about to go see patient XYZ. It's great we bumped into you, and we'd have a face-to-face conversation. Now, maybe there's interesting ways through virtual technologies to do this in other ways, but I just imagine a grand staircase with alcoves and openings and ability for exercise where this could be our new meeting place. This could be the new lounge where we have interdisciplinary conversations. So if we think about the role of hospital design overall, I would like to think that we're designing to break barriers. And I do think through design, we can make the training experience become easier and less traumatic for sure. And I do think the building is becoming part of the operational solution. So we can soften this metaphor I've given you of the hospital as a battleground for trainees. I do realize it's quite a harsh metaphor I've painted today. So we can end on some better pictures and maybe a more positive note. I think there are architects and hospitals out there working on some pretty innovative solutions. Here's a few. This is a project that focuses on wellness for clinicians. This is in Western Canada. This is a project by Stantec Architecture, modeled after a European example. You would think this is an atrium space that you would see maybe in a shopping mall or even a hospital for the public. This is only for staff. So this is a place, a vertically integrated, staff-only collaboration center, full of respite zones, nature, where staff can take a break, plan a patient's care model. A very powerful space dedicated only for staff. This is Guy's Cancer Centre in London, England, giving clinicians access to windows in all of their clinic rooms. You can see sort of cascading gardens if you look at the vertical section on the left, a cut through the whole building. And to address some of these deep floor plans in older buildings, because it's easy to say, well, we'll build new, but working in New York City, there's a lot of old buildings that need retrofitting. We can't always build new. Virtual windows. There's a huge role for them to play. In fact, there's a clinician out of Trinity College in Dublin, an oncologist, who did a wonderful study called Open Window that was published a couple of years ago, where he found his oncology patients just became so depressed, had to be in the hospital for so long, and he brought in virtual technologies. They could bring in images from home, virtual reality, and he found such an improvement in their quality of life. It was pretty amazing, his results. If anyone's interested, I can send them some of that information. This is Mount Sinai Hospital in New York City. This is a virtual window in the emergency room. And what about these on-call rooms? Are they going away? I think they are. And these sketches that I've done show maybe we don't need to even take such big, expensive real estate for a full room. Maybe we can do even just a lounge chair, somewhere to plug in your iPod or iPad and listen to music for 10 minutes. This idea has taken off so much that the American Medical Association, the AMA, came out with an article that termed something called a reset room. A place where doctors can go, maybe they put on some virtual reality, maybe they do yoga for 10 minutes. We don't know what it is quite. And the University of Toronto next week will launch a magazine with a number of sketches I've done to try to create ideas, and we'll have that online, and I can send out a link because we'd like to get a conversation going of what we think reset rooms could be. What do we want to see in them? But this is a neat graphic I thought from my American College of Physicians Hospitalist magazine I just got in the mail last week, with this wonderful graphic of, getting out the door of the hospital, nature pulling us in or calling us out. I don't know which. But Leland Kaiser, who I quoted on the slide, a hospital futurist, said, "We've invented the hospital, so as humans, we can reinvent it at any time. And I think now is the time. And we need to reinvent it for clinician wellness." So just some design trends going forward. I really think I've touched on these, but handoff spaces is something we're going to have to see redesigned because we just don't have the space for them yet. On-call rooms are really going to be respite spaces or reset rooms. And we're going to need spaces that look at increases in conference room time, collaboration space, and maybe the use of virtual technologies to get so many clinicians together. This movement towards universal design we're seeing as a trend overseas in Europe. Not as much in North America. We still focus on the word disability here and design for disability, whereas overseas I'm finding universal design is a term that's really taken off. And what about the future? What is driving the change in hospital architecture? We looked at care a lot more in the past. Tuberculosis sanatorium had no real antibiotics, so care was about nature. We moved into the era of cure and technology. And while medical science can often disguise mortality with technology, I think we're moving in a circle and we're going back to revisiting the sanatorium model to demedicalize architecture. So we're coming back to care. What about us as clinicians? What does the future hold for us? Can we resurrect the doctor-patient relationship? Intensive Care Medicine, the journal, ran an article by Dr. Vincent in 2016 where he tries to predict what it will be like in 2050, saying that doctors won't be doing procedures and interventions anymore. They'll be doing something else. The root of the word doctor in Latin is docere, to teach. And he said, you may think that sounds inhuman, but it's not at all. The doctors that are present are much more available to talk to you, to explain and to answer questions, to reassure you and your families. And so this is a graphic I tried to put together to illustrate this hybrid model of what is contributing to health. And in my mind, planning and medicine and architecture and design, they're all building blocks to health. And maybe I need to add some blocks for technology and virtual reality, health being more than just physical health, but also mental health. And I think here today, for me, health is more than just patient health, but health of clinical staff is paramount, and I think something we need to start talking about a lot more. So those are the little anecdotes I wanted to share today. I have some ideas about virtual reality and staff reset rooms, communication between staff, and communication with patients. I'd love to hear about who the audience is out there and any ideas you might have to share, and I'm happy to take any questions. Thank you very much.
Oh boy, you've given us a lot to think about, and we're getting questions from the audience already. The first one that appeared was one from Leandra. She worked in a hospital that had a large atrium with greenery and natural lighting supplemented for her very short Canadian winter days. People with seasonal affective disorder reported it made them feel much better. Have you designed for SAD?
So, I think it's a very good question. And being from Canada myself, I understand the 8 months of dark winter days. And having also done some work with people from Scandinavia, I think it's recognized a lot more in other countries. I'm surprised in Canada we don't recognize it as much as we do. I actually haven't seen a lot done at the level of architecture and schematic design thinking about SAD. Not necessarily with patients, possibly more with some staff, in fact, which is interesting because usually I'm always talking about staff and not really thinking about them as much. I'd like to know from her what was actually done at her location, if anything, and a little bit more about her story.
Hey, Leandra, there's one for you.
I'll just comment that they put the atrium in. This was at the Health Sciences Center in Winnipeg, and they put this big atrium in, and it had all this supplemental light, and it was an accidental discovery that it really helped seasonal affective disorder. It was not something they planned.
And that was noticed for patient staff or general users of the atrium space?
Well, we had a sleep disorder clinic right outside the atrium, and they're the ones who picked up on it first. And it was staff and patients and everybody.
I hope that somebody wrote that up.
I honestly don't know if they did.
See, that's the big challenge, I think, with architecture. There's a lot of anecdotes, and people will say they noticed something, and the challenge is how do we then capture that with real methodology and scientific research to then take that to another client, another project, and say these are real results, and then translate that into cost data, which unfortunately, when you work on the architecture side of things, clients and administrators want to hear about the return on investment. And there is some good return on investment data to show that design for better buildings has a good return on investment. But there is a more upfront cost you have to consider. But I love hearing these types of anecdotes, but it's also very hard to study them. But I'll look into that and see if there's been anything done. Because I've heard of the Health Sciences Center in Winnipeg. I've never been, but I'd love to visit it.
Okay, we have a question from Zip. What about those great designs for staff collaborations? How is the patient brought into that? How can the patient reset? How can the patient meet with their entire physician team? How can the patient get out into nature?
That is a great question. And I think that highlights another disconnect. I talked a little bit about a few gaps. The gap between architecture and medicine, the gap between design intent and user experience, even the gap between the care team. But you're right, I didn't necessarily touch on the gap between the care team and the patient. I think it's a challenging one. There is quite a lot of literature in the ICU data showing that involving patients in care planning is very beneficial. And that should happen and often does happen at the bedside, of course. I like your idea of patient resetting. So that's getting my mind thinking at the moment. I almost think that sketch I showed you of the ICU with the floor-to-ceiling windows that break open, where the patient could move out and have a reset moment outside, even potentially if they're not necessarily conscious, might be an interesting concept. There was, in fact, a study a couple of years ago which was a little bit of a surprise to the design community that windows in an ICU were studied and appeared to have no effect on patients, contraindicating a little bit about what we learned from our initial study in the 80s. But keeping in mind that in intensive care, patients might also be sedated and there might be other reasons that they might have no benefit. And perhaps windows might benefit families and care teams more in an ICU type of environment. But I think you touch on a really good point of how to integrate patients and families. We're doing that a lot more with our clinic designs, I have to tell you. Ambulatory designs, you might have seen that cancer center exam room I showed near the end, but we're trying to get away from the old-fashioned desk and computer, clinician on one side, patient on the other. We're moving towards circular tables, integrated computer systems, where patients can see exactly what physicians are doing, look at their imagery, really make it more about patient autonomy and interaction, and really make it more about the physician or clinician providing the patient with information and them making decisions together. But I like the idea about the patient reset quite a bit. I have to think about that some more.
Okay, we've got a rather long question coming up next. If I can get it to print. Faust says, are there implications from your work for landscape architecture and community and regional planning, such as could positive psychological well-being be proactively enhanced as a matter of public health policy through architecture, landscape architecture, and community and regional planning? He's broadening you out, I think.
I mean, definitely. I mean, you're touching on some big topics that are being thought of around the globe. I'm thinking a little bit about New York and some sort of city wellness guidelines that are being thought about, and healthy city design, which is actually a big conference coming up, which involves landscape design quite a bit. Thinking about, we heard a little bit about diet and nutrition earlier today, but also thinking about exercise in an urban context, landscape. It's interesting, but one of my geriatrician colleagues actually says that he doesn't feel hospitals will exist in 20 years from now. Very drastic view, but what if healthcare changes drastically? And it actually might be possible. Maybe healthcare will shift entirely to the home or to the community, and hospitals will be literally critical care centers for just a small amount of people. And then what you touch on is really healthcare happening in the urban environment, and then landscape architecture and community planning is really completely integrated with healthcare. It's not so localized as a hospital building. I think that's the direction we're actually moving towards.
Now, Xenia has a comment, but I think I'd like to hear you comment on her comment. Xenia says, more interdisciplinary concerns where art and design play a key role in fields that people considered, quote unquote, more serious.
I'm just trying to read that comment again.
Maybe people don't consider art and design as serious as they consider medicine.
I mean, that's possible, but I do think that our views are shifting so much. There's an entire body of literature on art and design as related to healing. In fact, if you think about one diagnosis in medicine, dementia, for which we really have no good treatments, kind of like tuberculosis, where we had no antibiotics at one point in time, and we use nature as treatment. There's a great book on architecture and dementia called Lost in Space, and it's all about utilizing art and space to try to generate memory and sort of provoke some of these essential human senses that we all have innate in us, and we use art and architecture to do so. It's very fascinating. So I really think medicine it's a ripe time for medicine to consider all of these ideas. Like, nothing is too crazy to consider. That day on rounds when they considered moving that woman to a window room, I thought they would laugh, and they didn't. I really do think medicine is ready to think outside the box.
Okay, and we have a question from BG. He wants to know, what role does culture play in hospital and medical design?
You guys are asking tough questions. That's a big question. The word culture, I think, is a very generalized question, and I can think of it on different levels. I think you can think about it from a globalized level in terms of country culture, and hospital design varies quite a bit depending on where you go in the world. But just a simple example of designing a new hospital wing, moving from, I showed you that photograph of the Florence Nightingale ward, of an open ward. If you take a culture like that with staff who are used to that type of space and you give them a new building of all private rooms, it's very difficult to change the culture. It takes months of training. There's a lot of rejection of the culture, rejection of the building, very difficult to work with. I think human beings, just change is very difficult for us, and we become used to our particular work culture in this case. And so anything we do with respect to design where we create change becomes a really big challenge. For a while we struggled with hand washing sinks. If we think about infection control, where do we put them so that staff will wash their hands? We make a change. We change the culture. So anything we do in design has to go with a culture change. I don't know if that's necessarily answering your question, because I think there's different levels.
BG says his question was directed towards the culture of the patient in their country or region. And I'm thinking the more we get, immigrants, it's going to be even more complicated.
I mean, I have no doubt it will be more complicated. I think with the culture that we have in North America and where we're going with the all private room model, it may be easier to integrate different cultures with that type of design model in some ways. Not all countries are doing all private rooms. I think it's a difficult model to sustain cost-wise in the future. For a while we were going bigger and bigger and bigger. And at one point I think you can become inefficient with size. An operating room can only get so big and then it becomes inefficient. Bigger is not always better. But I think as the world becomes more global, yes, there will be cultural questions. I do think, though, there are design solutions and we'll have to work them out. It will be harder to retrofit older buildings to address cultural changes than it will be to design new. It always is. And we'll have to keep in mind informatics. That's something that we I think is the biggest challenge for architects. Not necessarily designing for culture, but informatics. We often think about it later on, and there's a couple of my physician colleagues in New York who are trying to really push for that to be done early on. An IV pole is no longer just an IV pole, it's a computer. We can't just pop it in once the building's built. You need to think about that early on as you're sketching the room out. This all has to be incorporated, and maybe the idea of culture is something like that, where we need to incorporate that really early on. It's not something that can be done later as the concrete is being poured.
Well, that's a lot to think about. Draxter wants to give us something else to think about. He says he'd like to remind folks of the AVES project, Doubted Second Life, in 2010, and he's pointing to a YouTube. Draxter, do you want to say in voice why you think that this is important? I can say the AVES project is the Amputee Virtual Environment Support Space. It was funded by the U.S. military, and it provided an environment for amputees, military amputees, to get together and learn from each other. Okay, so Drax says, oh, right, in Germany, his kids are asleep, so he's going to type it. What was so important was that a virtual world really provided the window to the outside world. That's what Drax is saying. Drax is typing it. And during rehab, this was when you're a military amputee, your rehab often lasts for many months. Fathers could hang out with their kids, right? The fathers could come in the virtual world and be with their sons who were back from Iraq, and they could be together in worlds that they created themselves. They could create the worlds together. And they can do it now in Second Life. Right. Right. The project was funded as a preliminary, but it never got used, unfortunately. That's right. Okay, so I'm going to go on to, today we have better tech. I'm going to go on to Polaris's question. Polaris asks, what other technologies have been incorporated besides the virtual windows? And he's suggesting things like fragrance drops or atmospheric immersion auditory tech.
So other technologies that I've seen, I don't know a lot about the fragrance drops. As far as I know, we try to stay away from some of that in different oncology types of units. The auditory tech is interesting. There's quite a lot on music data or music research in ICUs, but I can tell you an anecdotal story of a digital, like a backlit panel digital screen with live feed, so video feed of like virtual, I don't quite know how to describe it, nature scenes that were sort of live with sound in an ICU. And they had a problem with a patient who was consistently delirious, consistently saying that he heard crickets, and they medicated him for quite some time until a family member said, I hear crickets too. And they realized that the cricket sound was coming from the screens, which makes you realize that sounds, there's tricky parts to sounds, especially in a critical care type of environment. So that's one example where it might have a negative connotation, but music in ICUs has been something that's been quite positive in the research. But more so with respect to individualized patient scenarios and not so much high tech that I've heard about. But if anyone has any examples, I'd love to hear about them.
Here's an example from Kaina, but I'm going to also say while I'm reading this from Kaina, and you can react to that if we can have one more question, I think that'll be about it. Kaina is saying your comment about a grand staircase made her think of one of the facilities where she trained, Legacy Salmon Creek Medical Center in Vancouver, Washington. They have one, so there you have a suggestion of a place you might want to go look.
I will definitely look that up. I'm always looking for photos, as you can tell, and sketches and different ideas to show in lectures, so thank you for that.
And I'm going to warn the audience, if you guys don't have one last question, I do. You know what my questions are like. Dragster does. Claire does. No. Okay. Here comes my question then. Do you find any relationship between the medical delivery system model, such as the national health insurance model, out-of-pocket social insurance, that kind of stuff? Do you find any relationship between that and the ease of acceptance of your model of architecture supporting the doctor-patient relationship?
That's a big question. I mean, in terms of ease of acceptance of the model of architecture, I think, there's definitely a difference in the acceptance of healthcare design between different countries and how their models of care run. So I definitely see a difference between Canada and the US as an example, in terms of the emphasis we place on this model of healthcare design. The sketches that I showed on where we put our resources for design, I think I see a greater discrepancy as a generalization in the US towards public spaces, only because patient satisfaction is such an outcomes measure, whereas it isn't necessarily that way in other places. So I see resources distributed a little differently, so design just becomes different. Spaces are much more unified in terms of square footage allocation. I found in some areas in the United States very large public spaces, very grandiose, and much smaller sort of back of house spaces where it's a little more unified in other countries, Europe and Canada and Australia. So a little bit different in that respect. I don't know if that begins to answer your question. That's a big question.
That's what I meant when I was saying that. Svea. Svea is at the Mayo Clinic, and he has a comment. Dr. Anderson, we agree entirely with your approach and comments about the importance of spaces for patients and staff. At Mayo Clinic, we have been actively engaged in research and experimentation in these areas for decades. Our conclusions match yours, and he would encourage your continued work in this area. Nicely done. That's a very nice comment, Svea, that to conclude this session on. So
Thank you very much. That was very nice.
And Mayo Clinic has a presence in Second Life you might want to check out. So I'm going to conclude and say that we've gotten so much to think about from you, Dr. Anderson. And here we are inside a virtual environment. So this is a little different for you too, I'm sure. So audience, please, let's thank Dr. Anderson for her contribution and sharing all her ideas with us. To me, it was very interesting to hear how emotional you were about some of your conclusions. Thank you very, very much.
Thank you very much, everybody. Thanks.
Thank you, Doctor.